In this third educational video, I will be talking about disease control of asthma. The aim of asthma treatment is control of asthma symptoms and prevention of exacerbations. Ideally, if a person's asthma is well controlled, they will have no daytime symptoms, no nighttime symptoms, and no limitation in their activity. Disease control is achieved through regular use of inhaled corticosteroid, which reduces the inflammation in the airways and makes them less susceptible to the bronchospasm that results in symptoms and asthma attacks. This protection improves over time, and so is important that inhaled corticosteroids are used regularly. Having asthma symptoms or needing to use a reliever inhaler 3 times or more in a week is an indication of poor control and is a reason to consider adherence, inhaler technique, wider environmental factors, and possibly stepping up asthma treatment. With good control, patients should rarely experience symptoms or need to use a reliever inhaler. You may have heard of the term SABA, over-reliance, which is defined as using 3 or more regular inhalers a year and is associated with poor control. The graph on the left shows that the overuse of short-acting beta agonist inhalers, or SABAs, is strongly associated with increased risk of hospitalization. In fact, using 3 or more SABA inhalers per year more than doubles the odds of admission to hospital, and the risk goes up the more SABA is used. On the other hand, regular use of inhaled corticosteroid inhaler is associated with lower mortality from asthma. For most people, asthma achieving good symptom control would involve using more preventer inhaler than reliever inhaler. However, in the UK, we prescribe more SABA inhalers than reliever inhalers. So are these patients achieving control of their symptoms? A UK real-world study looking at approximately 500,000 asthma patients found that around 2/3 are either just on a reliever or on a reliever and a preventer, but overusing their reliever, suggesting inadequate treatment. Frequently, if patients are prescribed separate reliever and preventer inhalers, then the regular use of preventer inhalers is low. This means that up to 2/3 of patients with asthma in the UK are likely to have their inhaled treatment dominated by SABA. Another study showed that 70% of inhaler prescriptions in the UK are for relievers, with around 50% of patients potentially overusing them. One option to improve disease control may be to consider a combination inhaler with both preventer and reliever. These can be offered to patients who are not responded to regular low-dose steroid inhaler and offered as a MART regime. In the MART regime, patients use combination inhaler with ICS and LABA regularly, usually twice a day, but can also use it when they have symptoms. The formoterol LABA has a short onset of action and so is effective for relief of asthma symptoms. So the combination must contain formoterol as the LABA. The MART regime should remove the need for a blue SABA inhaler altogether and can simplify therapy and reduce exacerbation risk with a lower total steroid use. The new investment and impact indicators on the PCN-DES contract have a quality indicator around the number of patients on 6 or more and the number using less than 3 inhaled corticosteroids in a year. These commence in April 2022. The number of 6 or more SABA has been chosen rather than 3 or more SABA for pragmatic reasons, so that practices can focus on patients most likely to be at risk of poor control and outcomes. However, your practice may choose to look at all patients using 3 or more SABA inhalers. So, in summary, we are prescribing too much of a medication known to be associated with poor outcomes, SABA inhalers, and not enough medication which actually reduces risk, inhaled corticosteroids. Furthermore, compared to the rest of Europe, the UK is the highest prescriber of reliever MDI inhalers. Addressing asthma control and prescribing habits would not only improve care and outcomes for patients, it would also go a long way towards reducing the carbon footprint of asthma care. The quality improvement projects in this section help to identify patients who are at risk of poor control in daily practice. during medication requests, during any clinical encounter, as well as in routine care, such as the annual review. They include searches so that patients at risk of poor control can be prioritised for review. They also include resources for patient education around disease control. Thank you.